Welcome back to another episode of the Empowered by Victorious podcast. If you are watching, you will recognize this face. She has already been on here with us once. If you're not watching and you're just listening, today we are joined by Bethany Vitko, again, occupational therapist and pelvic floor and core expert in her field. Again, she works out of the Victorious Lincoln location. She works for Wellity alongside Mary Jane, but it functions out of both locations. So she's a great resource to have within our space and within the women of the Wellity community and just Lincoln at large. So thank you first and foremost for your time in doing this with me today again.
Super excited to be here again. And hopefully more.
We joke that we're like two ships in the night, like always passing each other and not necessarily connecting all that often. But this week we've had more.
I was going to say, like, this week has been, again, by far more than like the entire year. And I've loved it. Like, it's been so nice and good for my soul.
I know.
To be able to see you so much. And I think I am hoping, and I keep telling myself this, that the reason that I haven't seen as many people like passing at Victorious in the halls and things is because it was summer. Now it's back to kind of the norm. And so I'm excited for that. So,
well, you're also a very busy woman. Even if you're here, you're very busy.
Yes.
And obviously
Yeah.
likewise too. But
right.
I just got to spend an hour on Bethany's table and let her work her magic. So if I've got sleepy eyes, that would definitely also be why. When she's got that magic touch for whatever reason, it just always starts to make you sleepy. Well, there is a reason, I suppose, for that. That's a different conversation. Yeah. Well, we wanted to, Bethany and I have been talking about like what did we want to talk about specifically today. Again, both her and I can go down a rabbit's hole, both being extremely committed learners, down a lot of different things. But I think pelvic floor is something that we've talked about this in previous episodes a little bit, or I have, how 7 years ago when, Victorious was just getting, or I was just getting started within the fitness realm, you were just getting started within your private, within your practice.
Mm-hmm.
Pelvic floor was just starting to be something that people would discuss or bringing attention to. And when it was discussed in more extreme situations, correct?
Mm-hmm.
Trauma and probably mostly related to birth, right? Like maybe I'm generalizing a little bit there, but right?
Well, I think birth injury was huge, but also the majority of people that, like, if it was a young person referred, it was probably a horrible birth injury or, a horrible injury of some kind, or really major pelvic pain or something like that. Otherwise, the only people that were, I think, referred frequently was the older population for incontinence type of things. It was just kind of those extremes, and people who could really benefit from it were just either weren't aware at all or were didn't think that maybe it was too taboo for them, or maybe it was like, oh no, I don't need that, or this is totally normal. I've had a child, no, I can't do X, Y, and Z anymore because
I had a baby.
That's just how it goes. So
right. I remember having that exact conversation with my mom when I was 21. I was 21 when I had my first son. And I remember my mom saying, or no, I needed to go to the bathroom. It was probably like a week postpartum, which obviously is very normal. But I had to go to the bathroom, and I had to go to the bathroom right then. My ability to hold my pee was essentially nothing. Obviously, birth-wise, yes, trauma at that time was very normal, but I just remember being like, what the heck? I can't even control this right now. I gotta go now.
Mm-hmm.
And she's like, well, yeah, you had a baby. And I'm like, well, yeah, but this is it? This is what I'm gonna deal with now? And she's like, well, yeah, you had a baby. This is how it goes.
Yeah.
And I'm like,
You had a baby through your vagina, so now
Right.
it doesn't work anymore.
Now it doesn't work
Like
anymore. And I was like,
the way it did.
oh,
Yeah.
right. And then I had another baby, shortly after. And well, I think it to my advantage a little bit at the time. Like I was very young when I had my babies. And so, even though I had episiotomies with both, I feel like I healed fairly well considering that
Hmm.
and, was able to like function very normally. But then with my third, obviously being very intentional about those things. And, but yeah, I think pelvic floor just it was those extreme cases, right? Like you said, like the
Hmm.
prolapse in the older individuals, but then the extreme birth trauma in the postpartum
Hmm.
individuals, and there's a whole spectrum of people that would benefit from pelvic floor therapy that we're not talking about and now. And I think that slowly but surely, like things are starting to get asked and starting to connect the dots to something. I think high impact sports athletes are starting to like, bring awareness to a little bit of this, the gymnasts and like those types of things that have
Hmm.
maybe had some trauma from the way that they, performed their sport over the years. And here at the gym, like, and I think, every gym is different. Every, screening of what they do for their members is different, from exercise readiness to, mental health screening a little bit, I think, and just making sure that we're doing our due diligence that this person is ready to exercise. But here we also do like a very small little pelvic floor screening, and it's the pretty typical symptoms, right? Like heaviness, you know, loss of
Incontinence,
incontinence, yep, loss of ability to hold your pee. Um, what else we got in there? Pelvic pain.
pain.
Um, there's like pretty basic, like the consistent. And maybe you can rattle off more of that, like more basic. What the world would expect is maybe pelvic floor related.
So I think we think bladder, bowel, sexual function, right? Like the things that are right there. And that's true. All of those things are um, pieces of the pelvic floor and are what is, um, what the pelvic floor is in charge of in terms of it. Our pelvic floor comes from our pubic bone in the front and it goes to almost like a diamond over to our sitting bones kind of in the side and then the tailbone in the back. And so, that wraps around and kind of covers the clitoris in the front. So that's going to be sexual function. The urethra is in there, obviously, the vaginal canal. The perineal body is the space or the tissue in between the vaginal canal and the anal sphincter in the back. And then there's the anal sphincter. So it just like in that external portion, it's covering those things. I think that's primarily what people think of. And again, that is the pelvic floor. It has a lot of other functions that I think, or there's a lot of other pieces in our function that the pelvic floor plays a role in. And that I will say, so I think it's been like 8 years since I started. When I started, it was still a lot of like either you were a therapist looking at the pelvic only at the pelvic floor,
Mm-hmm.
or you were a therapist who didn't really touch the pelvic floor. Maybe they said maybe you see people with pelvic floor issues, but it's all exercise or all just improving the pelvic position and not addressing the actual pelvic floor at all.
Right.
And I think just with more research and more understanding, we know that yes, it is a group of muscles and there's, these 3 layers of the pelvic floor. They should work together. They should coordinate. They should also be able to do a few different functions than one another, the ability to pee and not poop at the same time or so on and so forth. And, but we also have this, it's really important for stability and pressure management of our core. And it is very coordinated with our breathing diaphragm up at the top. And so, both neurologically and pressure management wise. And so, yes, we have these symptoms, whether they be urinary incontinence or fecal incontinence or constipation or retention or pain. Those are probably going to be kind of the biggest symptoms, but they're going to be stemming from far different things than just what's going on in that like little diamond of muscles.
Yeah. And I think in the postpartum, in the demographic that we serve, very consistently, I think the two, scenarios that we hear concerns more from, like specifically, like I'm feeling this way, would be in the postpartum time period, or, well, after they've had a baby. Postpartum is forever. Or, like you said, like the more advanced aged woman, more mature woman. And obviously we can go into why the reasonings for that, from a hormonal perspective too, but there are so many more things than just like doing kegels, right? Like, I mean, at the time, when I first had my first two, again, like 16 years ago, 14 years ago, like, I mean, I remember my doctor talking about kegels, and like, just make sure you're doing your kegels, like when you're at a stop sign or when you're, think about it or whatever it may be. And I'm like, okay, like, as long as I can stop my pee, apparently then my pelvic floor is okay. Like, and that was the extent of, the education. And now we know, from our perspective as fitness professionals, if we're being told of any of these things that are happening within exercise or outside of exercise, number one, we're referring to a pelvic floor therapist, but also, like you said, ideally somebody that's also specializing in the core, because it is this like correlation of, that's like integral, that they need to be like functioning together. But what you're doing is also like even outside of that, right? Like it's even bigger than just core and pelvic floor, simultaneously working synchronized.
Well, yeah, I mean, I think you can say, okay, we're going to look at the core, or, just like this section between the diaphragm and the pelvic floor. But how much of that is, for example, if there's dysfunction between the respiratory diaphragm and the pelvic floor, and there's not as good of like range of motion or excursion of that diaphragm, what's coming from that and what's coming from the upper body? Like how is the upper body then playing into that? And so we can't just say, like, in every scenario, okay, we're just looking at the coordination of the pelvic floor and the breathing diaphragm or whatever. Like, again, that's why it has to be like this whole person approach. And to take it a step further, we can't even always look at what's wrong with the muscle. It also has to be like, what else is going on in this person's body that's making this muscle be either overactive, or what's it protecting? Why is there weakness? Was there an injury? Are they overusing their like larger stability muscles instead of being able to get more of these like local stability muscles to kick on and stay on like they need to? And so I think it's just, there's probably no pelvic floor therapist that can be and that wants to be really good at everything.
Right.
Like because of how broad the spectrum of pelvic floor dysfunction or core dysfunction is. And so, one person, like I really enjoy looking at how, like the yes, of course, the core and like the musculoskeletal system or the neuromuscular system, like the nerves are obviously really important. Our nervous system is really important. Um, I I definitely care about that, but I'm also looking at what inside or underneath that could be contributing.
Yeah.
You know, is there scar tissue? Is there digestive dysfunction? That's like the primary thing. Is there something with the lymphatic system? I love pulling in the lymphatic system with everything because a lot of times there can be a piece to that. Or is it something where, like, you know, somebody had an old knee injury or an old injury, orthopedic injury, where that just kind of threw off their pelvic position and now their pelvis is stuck in a position, and you know, that's the driver. Like we kind of have to figure all of that out, and then just and acknowledge how these different pieces play into it.
Yeah.
So
Is there any way
one
that someone like myself, or maybe somebody even less, maybe more body aware, could say, okay, like, essentially, if I have this list of symptoms that are typical, like pelvic floor symptoms, I don't relate to any of that. So I don't believe that I have pelvic floor symptoms, but I have, digestive system issues, or I'm suffering from low back pain, or, I'm having a difficulty breathing within like a respiratory standpoint or something along those lines. How would I know that it was also maybe, that the pelvic floor correlation could be there, or would both be present? Would I have some potentially like some pelvic floor symptom along with these other like issues like the digestive system stuff?
you might the person may not have a symptom at first, right? Like that's probably where it it would maybe start with you know, maybe our breathing is off and that's okay for a while.
Mm-hmm.
And again, we're compensating and we're doing things, and then you have a baby,
Mm-hmm.
and there, even if there's no tearing or even if there's no, you know, major things, there's been this huge shift.
Mm-hmm.
And you then, you know, maybe then that's kind of like putting that over the edge, if that makes sense. Now, in terms of like how the if you would not have symptoms but yet maybe have pelvic floor dysfunction, yeah, I mean, you can it can be you can have a symptom of like bloating. I mean,
Yeah.
essentially that can be a piece of pelvic floor, you know, thing. Like that it doesn't have to be just that I'm peeing or that I'm have some issue with like um fecal incontinence or pelvis, you know, significant pelvic pain or anything like that, pain with intercourse. It can be these other things that are like, oh, your pelvic floor is probably a piece of that. You know, the pelvic floor is probably really overactive at the bottom, and your abdominal muscles in the front are, you know, those are a lot more lax. And so your pressure management or your pressure is pushing into the front and kind of contributing to a lot of that once there's any type of eating happening. You know, maybe it's just a response, it's a pattern from something that someone's eating.
Right.
So,
Right.
sorry, that was like so all over the place, but
No.
you know, it's,
Well, it can
um,
be,
yeah,
apparently.
seriously,
Like
like it's
it can
just
be.
so, there's so many things that go on in it.
Right. And I think that that's something just to like normalize in the conversation around pelvic floor, around pelvic health,
Mm-hmm.
around, women's health in general. Like this isn't just a postpartum thing. This isn't just a, you know, postpartum or pregnancy can exacerbate an issue that maybe was already there.
Mhm.
And birth in and of itself is a trauma. Whether you have had a C-section or a vaginal delivery, there is still like pelvic floor and core, you know, injury to a certain extent, is probably, that sounds like a bad word to use, but it really is,
Mhm.
from a tissue
Yeah.
perspective.
Mhm.
And so it can, those stages of life can exacerbate things or cause things, issues in regards to pelvic floor, but there can also be other things at play. Like, I would imagine chronic stress is probably something that would cause, pelvic floor potential
Mhm.
issues later on down in life, right? Like, speak to a little bit in regards to like the correlation between the jaw and the pelvic floor. I find that
Mm.
very fascinating.
Well, um, just a sec. So I wrote down, so I was telling you, Stacey,
Yeah.
before that I wrote
Yeah.
down like a list of um things that's like the same symptom,
Yeah. I love
but
that. Yep.
is from different. And so I will get to like that's absolutely
One of
a
them.
a
Yep.
correlation. Yeah.
Yep.
So pelvic I wrote down, from um incontinence. I wrote down incontinence, constipation, and pelvic pain, but I will just go to pelvic pain. And these are like situations that I've seen someone with pelvic pain, and the um, source of it is so different.
Okay. So everybody's
um,
pelvic patient XYZ, one, two,
mhm,
three different people presenting with pelvic pain. Um,
mhm.
but we're going to hear different reasonings for that.
Yes. So, one of them, endometriosis
Mm-hmm.
and scar tissue. That's a podcast in itself that we can talk about all of the things. Um, pelvic venous insufficiency, or like pelvic congestion syndrome. That can contribute to a lot of to pelvic pain or pain with periods.
What is
Um,
that exactly?
so it's where the veins or the venous system, the cardiovascular system, like within the pelvis,
Mm-hmm.
is gets like kind of overloaded. There's no longer good kind of transfer of that fluid. There can be then fluid and things left in the pelvis, and it can often cause like maybe sometimes the symptoms are like a headache or really like pressure in the pelvis, and other symptoms. Sometimes people have varicose veins or like vaginal varicosities and things, and it can cause a lot of pain and dysfunction.
Yep.
Um, and from that, someone might have an overactive pelvic floor
Sure.
because of that. But then I thought about this because I also wrote down just like stress.
Yeah.
Excuse me. Just someone can have had no apparent trauma or no apparent thing that happened to their pelvic floor, and they can develop like pelvic pain. And it doesn't have to be like vaginal pain or anything like that. You can be feeling this pain like deep within the hip or in the sacrum or the tailbone, or like, deep glutes type of feeling.
Mm-hmm.
And um, oftentimes people with this, or when I'm kind of getting maybe like a little indication that someone might have like overactivity of their pelvic floor, they're telling me these different symptoms, and maybe their pelvic pain also correlates, or they also have constipation, or they also have a little bit of incontinence, maybe not, but maybe. And I oftentimes will say, do you have any history of TMJ, or do you have any jaw pain or anything like that? And, you know, oh yeah, I do have, TM, or it's something like oftentimes, not always, but often. And there's a lot of correlation between the jaw and the pelvic floor, in that, okay, this area, our larynx or the oral area is the beginning of our digestive system. The pelvic floor muscles are the end of our digestive system. There is neurological connections in that in terms of the pressure management that needs to be happening all throughout here. And so, additionally, like we will hold just body pattern wise, and where we hold tension is often in like our jaw, our shoulders area. I'm
I was
going to
gonna
say
ask
too,
if it
like
was
the
like really,
diaphragm.
I was gonna
Yeah,
ask
like
if like traps were something that you
yeah,
flagged in that.
yeah, the diaphragm, some like ab grippers are just like kind of tense here, and then the pelvic floor at the bottom. And there's a variety of different like things that this may present as. So, some, again, like I said, abdominal grippers. Sometimes people's pelvis is like tucked underneath or really tight. That's not always the case at all. So there can be like an anterior pelvic tilt or a variety of different pelvic positions, and someone can still be holding a lot of tension in their pelvis. And no, I will also go a step further to say that like no position is perfect either, based on people's like normal anatomy and things. But there should be a balance, an ability to let go, or like a range of motion in like all of these levels, all of these diaphragm levels, in order to have optimal function. And
So essentially you're
oftentimes,
saying like a person, there's not like when you see like the picture of a skeletal muscles and like the skeleton on the screen or in a printout or whatever, and you learn it in school anatomy, like no person is walking around like perfectly symmetry like that all the time,
yeah,
right? Like there's
no,
not, that's not even really necessarily the goal for most
mm-mm,
people. It's
mm-mm,
you're wanting the systems and the muscles and the bones and the digestion and like the, all of the different body systems to be functioning optimally and not necessarily compensating for any changes, but like, working together in a way that like is causing like a flow state, right? Like essentially,
yeah,
is that what you're saying?
yeah, yeah. Like our body wants mobility.
Hmm.
Our body, everything in our body wants to move. And like if you take like an osteopathic approach, or if you have any education and training in like a visceral approach, you know that everything has an inherent motion. And literally from the like embryological studies, things are moving and then they kind of migrate to their area and move. And from the, if you're looking from at a microscopic level, to the organ level,
Hmm.
to our body, our body needs to be moving. And a restriction or a lack in that mobility, whether it be skeletal, muscular, neurological, visceral, lymphatic, whatever it is, like stagnation in that is not allowing our body to function at its best. And then oftentimes we'll get the compensatory patterns around that.
Yeah, that makes sense.
So, yeah. So if it's, just going to the diaphragm, someone's diaphragm might not have a full range of motion. And, somebody might be having jaw pain and somebody might be having pelvic pain. And first of all, where that's coming from, we don't maybe know. And it might not, like, yes, it might matter, but if we address it all, it doesn't necessarily matter if we address it all.
Mm-hmm.
But, if kind of the source of these things is it seems like the diaphragm's really not moving very well. But this person has a decreased ability to rotate
Yep.
or side bend side to side. And so that diaphragm has decreased motion. Okay. So obviously that's impacting the pelvic floor.
Right.
And maybe this person doesn't have incontinence yet or pelvic floor symptoms or whatever yet. But we want to improve that coordination of both of them so that the body is functioning properly. Whether they're bending over to pick something up off of the floor, or whether they have a barbell on their back and they're trying to, or their shoulders, and they're trying to do, max squat or something like that. Our body needs to be able to kind of function appropriately from that. Going back to the diaphragm, it could be that, there's restriction between the things that are attached to the bottom of the diaphragm or to the top of the diaphragm or rib cage that's impacting that. And so it's important to find someone. Well, first of all, it's important to know that yourself, that it's not necessarily just like one thing, but it's important to find someone just in general that's going to be able to know that it's not just one spot or just one, source. And then if they can treat you, that's great. If not, they should help you find someone who is better at that,
Yeah.
and whether that be like that you guys try to work it out or figure it out at first and then acknowledge like, I think there's something different going on, or like, why does this keep coming back? Like that's something that I really try to, I don't want things coming back like over and over again, and if they are like, if we're obviously we can use like a muscle energy or a pelvic repositioning exercise to get that pelvis moving better. And then they come back in. Why is that going back? Is it because there's scar tissue from an ovarian cyst that burst? Is that because there's endometriosis? Is that because they had a C-section? Is that because XYZ? Or,
Right.
But it's awesome and it's so cool that it's so complicated, but also it's complicated.
Yeah.
The things. It's not just like hey, let's do your kegels and then you're done. Like,
Right.
I think that was another thing that I had mentioned that I kind of wanted to talk about is like kegels.
Yeah.
And
Well,
I
and
think
I think to your point here, real quick, like
yeah, go.
let's say, we talked about pelvic pain being a symptom,
Mhm.
incontinence being the next symptom. Like let's talk about that because I think that plays into Kegels pretty
Oh,
strongly
yeah,
here.
yeah, yeah.
So let's say a patient comes in with, incontinence issues. Um, what have you seen, and why would they be experiencing that symptom within their pelvic floor? And I think a lot of people default to, I just had a baby, my muscles are weak. Those are
Week.
probably the two like things
Mhm.
that people think. And I think it's important that we talk about, okay, like what's actually potentially going on here.
Mhm.
um and we can talk about obviously how Kegels play into that.
Yeah. So, the incontinence, I that is a big thing that I see. It goes in waves, right? But like right now I'm seeing several people with incontinence. And a few things that I wrote down, or like a few people on my caseload right now, is I didn't even write down weakness because like that's just what everybody thinks of. Or I didn't write down weakness in terms of like I just had a baby, my pelvic floor muscles are weak, that kind of thing. But
Because a
I
lot of times
do
it's not, right? Like a lot of
right.
times it's not
Yeah.
even. we
Yeah.
think that it's that because it's not working. Like
Yeah.
in our brains, it's like, well, I can't hold my pee, so therefore my pelvic floor muscles must be weak.
Yeah. Yeah. And again, it's not something that's just that simple. It can be. Like it absolutely can be. I have someone right now who has there is a lot of weakness, but there's not weakness, it's not overall pelvic floor muscle weakness. Like her third layer, the third layer of pelvic floor muscles is very overactive. But the third layer is more in charge of like kind of helping to hold up or support our organs, is more in charge of like bowel function, and other things like the lymphatic system and just other stuff. But the second layer, which is more in charge of like bladder, kind of wraps around our urethra, that's very, very weak. And so I almost to the point of where I think that there's like something neurological a little bit going on, because she can do a kegel, and but it's part of the pelvic floor and not the rest of the pelvic floor that's going, and specifically not the part of pelvic floor that she needs.
Right.
But this is like more of an extreme incontinence. Like I'm walking and there's incontinence.
Yeah.
Okay. So, there can also be like stress incontinence, or, most of the time I'm fine, but I cough and I sneeze and I am not.
Yeah.
Again, people usually think that that's weakness. Oftentimes, like if that's something that came up after, being pregnant, sometimes that's a body shift, or like your weight has distributed, the front of you has become more lax, or there's like a lot more length in kind of the front, more that can sometimes translate to weakness, or maybe somebody has lost their activation of the deeper core. And so that can also contribute. They can have really good like kegel and really strong, and the timing of that diaphragm, or the timing of the coordination of the ability for that pelvic floor to come up when there's a downward pressure coming down has become poorly coordinated. I oftentimes see that with people who are holding their abdominal muscles a lot, like really holding in, or pulling like up with their abdominal muscle or their upper abdominal muscles. So not necessarily like gripping down, or their abdominal or their rib cage is coming down, but it's like they're kind of holding tension up like this all the time. That oftentimes will contribute to like overactivity in the pelvic floor. And so I'm sure you've seen this before, but like a tight a tight pelvic floor is not a strong pelvic floor. We need to have that good range of motion. I also
I describe that sometimes as, in the gym setting, I describe it as like, it's like doing an isometric hold, you know, with
Mhm.
with a dumbbell in your hand, you're doing a bar or dumbbell curl, let's say, and I asked you to just like isometric hold for, 2 minutes. And now I want you to start doing bicep curls. Like your ability to do that bicep curl is much less, because of the fatigue that I just put you under during the
Mhm.
isometric hold. And so, that's how I describe the pelvic floor tightness in the gym. Like obviously not from a diagnostic standpoint, but just as simple as
Mhm.
it doesn't necessarily mean that it's weak, or that you have a
Mhm.
weakness all the time. There could be an overactivity as well. There could be a lot of different things in this regard. So just describing it to just like the not lay person, but just
But
an
yeah.
average woman in the gym, of like, okay, like this, your ability to hold on to the things that you're wanting to like hold on to when you sneeze or you jump, or all of those things, when your pelvic floor is tired essentially from the tightness that it's holding, is
Mhm.
now minimized. And
Mhm.
usually if I can articulate it that way, they're like, oh, like that actually makes more sense to be able to um understand like it's not like you're doing anything wrong. And sometimes in that situation, and correct me if I'm wrong, Kegels could be one of the worst things we could be doing.
Mhm. No, I will not correct you because you're right.
Right.
Yeah, yes. So I am not a like I don't like Kegels type of person.
Right.
I think so because one thing that has kind of annoyed me, I'm not gonna lie,
Hmm.
um, throughout like social media and things, it's like, oh, we'll fix your like we'll do this pelvic floor without doing any Kegels. And
Hmm.
that's great, but that's not right for everyone.
No.
Like, because I have absolutely seen where, okay, let's say somebody has overactivity of their pelvic floor. I am not going to give them Kegel contractions. I'm definitely not. Um, but so we're going to work on things to help to downtrain. Okay. However, now you tell me if you have been holding your pelvic floor to the point of, or like your arm. So say we're like holding our arm really tight. And people also, I guess we could say this in our shoulders too. Say I tell you to let go, right? Like you're going to be like, okay, am I letting go? Like,
Thinking about it.
am I letting go? Because I don't see anything happening. I don't, I have no idea. I can't even feel that. Sometimes the biggest problem with people's, that's causing an issue with their pelvic floor is a lack of awareness. And like,
Yeah.
I don't even know what is happening here. And so I oftentimes tell people this, I am not giving you Kegel contractions in order to strengthen your pelvic floor. But if we can like activate a little bit here, because that's kind of the only thing you know how to do, if we can kind of activate a little bit and then think about letting go, your brain and your body is going to be like, oh, that's the spot. Like that's what I'm supposed to do. So it's really more of like I don't know if you've ever heard of progressive muscle relaxation, but it's more of this like progressive muscle relaxation where we're kind of like, oftentimes again, people will be recommended that for like this for overall body relaxation. And it's great for that because when we have this, when we're constantly holding tension and we constantly have stress, we don't know how to let go. And so a pelvic floor contraction can really help with that. And like really focusing on the pelvic floor can really help with that. Now, there's other things that, like, it should not be only that. There's other things that we should be doing and people should be understanding, like, you know, when they should be paying attention to, are they holding? What are some exercises that are going to help to improve the length of the pelvic floor so that we're not only improving our awareness, but we're also able to get length in the pelvic floor muscles so that we can kind of put these two things together. And, I've heard many times like Kegels are so not good, but they can be a useful tool both in this situation of overactivity in the pelvic floor, but also if there's weakness. We can do, there's a study that was done not very long ago that showed that the amount of pelvic floor muscles, now don't quote me on this, but we can link the study because it's good. But the amount the amount of pelvic floor muscle activation didn't necessarily like correlate with the like a squat. So what I mean by that is we can absolutely try to facilitate like the optimal coordination of the pelvic floor using the breath and using movements like squat or other corrective exercises. but it's not always working optimally in those situations. Sometimes people are so patterned to put pressure down during those movements, whether it came from being weak, and then, kind of trying to bear down, or whether, there's different situations. It could be coming from the diaphragm, whatever. But it's still important to train if that's necessary. If somebody has significant weakness or significant unawareness, I think that's a word, of their pelvic floor during movement, it still can be very helpful to train a pelvic floor contraction. And usually I do this with like a little bit, like 20% of a pelvic floor contraction, not max contraction, but just a little bit of that with movement, and kind of just, it's re-education. It's neuromuscular re-education. And so the Kegel's definitely not an end-all be-all tool, but if your pelvic floor therapist, or if your therapist is saying, I will not use Kegels or whatever, like, I think that's missing a piece too, when sometimes it could be completely appropriate. Or,
right. And
yeah.
Different ways not different ways to do a Kegel, but you can absolutely do a Kegel wrong in a lot of different settings too. Like,
absolutely.
I've been privy to like listening to you talk to patients as well as myself, and different cues that you give based on what part of the pelvic floor you're trying to get them to activate is very different. Just because I know like that side of like what the verbiage that you're using. Some people are tactile, right? Like some people are, even putting it within a what's the word where you're touching them exam?
Appropriate, or like, yeah, tactile.
Tactile exam where your finger is actually in the vaginal cavity.
Internal
exam. That's the word I'm looking for. Thank you. Where you're like, they're doing a Kegel like on your finger essentially, and you're able to like feel like, okay, like different activation techniques there, or different activation levels. I know verbally you've used, picking up a blueberry at a certain percentage, like you don't want to squish it, you don't want to like squeeze it too much. There's a bunch of different like verbal, obviously, and then tactile. But one tool that I think that you have at your disposal that is unique in regard to figuring out, because we're talking about like a bunch of different things that could be going on, obviously, like from the top of your head to probably your toes in regards to like causing pelvic floor stuff. But one tool that you have is that ultrasound technology, which I think is so unique. And so not only from your perspective in regards to being able to actually see what's going on, but from a visual learner, treatment on your side of things and within the professional service standpoint, whether that's physical therapist, chiropractor, occupational therapist, like body work individuals, you're trying to teach body awareness, right? Like as well as like treat the issue. In the fitness space, we're doing the same thing. We're trying to create the correct movement pattern, as close to the correct movement pattern that we can, and create body awareness. And we have to do that through verbal cues, tactile cues, and visual cues. Depending on the person, those things hit and relate different, and they respond differently depending on the learner style, their body awareness, like all stage of life, all of those different things. So maybe speak a little bit about like that ultrasound technology and how that can help this, like, because we've talked about a lot of different things that could be happening down there, right? Or not even down there. So how does that play into the way that you're, treating your patients?
Yeah. So, ultrasound imaging is what I use. And it's rehabilitative ultrasound imaging is what it's called. And we can use that we can use it on muscles all throughout the body, but I use it on the, like, specifically, or most frequently, I use that on the lateral abdominals. So our deep core, like the transverse abdominis, and then our obliques on the side. I will occasionally use it to measure like a diastasis or something like that. And then we can use that either over the abdomen or transperineally, so just like over the perineal body or the labia, in order to see the bladder lift. So we can see the pelvic floor, and we can see a variety of like views of the pelvic floor and how that's activating. And then, so without imaging, you really cannot say that we know, like, if we're activating the correct core muscles. Like, you just can't.
Well, there's so many of them, and
there's so many of them, and they share fascia. So they, and also, you know, even if somebody is like trying to get you to isolate the transverse abdominis, it doesn't work in isolation, or like we don't want it to work in isolation. Like we don't just want the transverse abdominis to just be working. We want it to work in the appropriate manner with the other abdominal muscles, like the obliques and the rectus or the six-pack abdominals. Additionally, the upper, middle, lower transverse abdominis are different fibers. So we can have overactivity, or we can have good activity in the upper abdominal, like the upper TAs, and poor activation in the lowers. And so doing like a palpation, which is how I used to do it, and I still will do that sometimes after I know how they're activating. But a palpation, like maybe on the inner hip, or kind of watching someone, you can be feeling different things. Like the precision of what it takes to be able to feel if it's really the TA versus the IO for the internal oblique is difficult. And so anyways, we can also look at that, and then we can look at the pelvic floor, and we can see if different activities are causing a lot of pressure down on the pelvic floor. So maybe so the bladder kind of sits at the base of that. The bladder's here, and we're able to see the base of the pelvic floor. So this is through the abdominal wall. The bladder here, when someone's doing a Kegel contraction, I should see it lift up like this. When someone is pushing down, I should see it come down like this. During an inhale and an exhale, if somebody has good coordination, maybe it's looking like this, like inhale down, exhale coming back up. But say then somebody, I have them do an abdominal activation, like do a core activation, and I want them to activate their pelvic floor and their core at the same time, and their bladder's like, and gets sandwiched. We know that they are contributing to pressure, or that is contributing to pressure down on the pelvic floor. And so that is not usually something that I can feel. Like sometimes yes, but sometimes no. And so it just kind of takes it a step further in being like, this is what's happening, and that biofeedback for someone to be able to see like, oh, you know, even just if they're trying to activate their transverse abdominis, or if they're trying to do a pelvic floor contraction, and say I have them do a pelvic floor contraction and that bladder maybe moves like a little bit or goes down. It oftentimes goes down. And then we talk through some different cues, and then we see the pelvic floor lift, and they're like, oh, okay, that's how that's supposed to happen. Same thing with the TA. Like if somebody is overactivating or compensating with, you know, more fast twitch muscle fibers, like the obliques, they are, they might not be getting transverse abdominis activation. And this is not just people with a lot of weakness. This is people who have a lot of muscle tone. And they can still be using what?
I said she's talking about me.
No, no,
No,
no,
I mean, but I
no.
mean, same. Like you can, I have been on your table, seen these things. Like I have suffered from, overactive rectus abdominis, not as much TA in the past, or I'll grip in the upper, or, like it, and it, for me, I think it kind of evolves. Like it kind of changes based on the intentionality of what I'm doing intentionally for my core from a breathing perspective, and
Mm-hmm.
rehabilitative perspective. Like, but yeah, I think it's, you can sit there and have a six pack on your body, but that doesn't mean that your core is functioning. If anything, at
Right.
times it could potentially mean that it's actually not functioning optimally,
Mm-hmm.
in regards to overactivation, right?
Mm-hmm. Yeah. Yeah. Um, so the ultrasound is also not an end all be all. I
Hmm.
still do internal assessments because I can see, like, the ultrasound's so good for coordination. It's so good for training. Um, but I can't see or release pelvic floor muscles that are
Right.
tight.
But you're able to utilize the ultrasound in a way where they're turning and watching like what you're
Mm-hmm.
asking them to do, and they can see like you can visually show them, okay, this is your pelvic floor, this is your TA, or wherever we're at, right? And they can watch based on your movement pattern and the cues that you're giving them. Like I've watched you use, this cue, okay, that's not working. So we're gonna try this cue, and then okay, maybe that's starting to work. Like
Mm-hmm.
it's a tool to, like you said, to educate their body awareness. Just it's not going to release anything necessarily like you're saying, but it's going to at least help create like their own body awareness on as to what they're doing right, wrong, different, whatever
Yes.
you want to call it.
Yes. And awareness is the first step. And I mean, I know you said that, like, in the gym, that's something that you're really trying to improve to, or bring awareness to, is a body
Right.
awareness.
Educate.
And like,
Educate.
if that is like the one thing that somebody gets from treatment, or from using the ultrasound, or from doing the pelvic floor assessment, or from doing some different exercises, um, I think that's the most valuable tool. Because, when we are just going through daily life and it's like, gosh, why is XYZ hurting, or why is this happening? And then you, you like really tap into the way that things are feeling in your body. And maybe one side, gosh, I am just always like, when I'm trying to do something, my right leg is just gripping, or like so overactive the whole time. And, I'm just my front and my back, the back of my leg, when I'm supposed to only be activating my hamstring, or when I'm supposed to only be doing this or that, that's just constantly firing. How can I get that to let go? Okay. Also, same thing like with the pelvic floor. We're not even able to see that. But if we can figure out how to figure out what it feels like to lift, when I need to lift, figure out that, oh man, I do this one, movement, or when I'm picking up something heavy, I'm actually pushing down on my pelvic floor. That's what's going to contribute to like the long-term changes, not like just a muscle release.
Right.
Like
Just the tool.
it's the improved awareness and their improved independence in their ability to um live, function,
Yeah.
like,
No.
pain or symptom free.
Same.
So
Same. On the
yeah,
fitness side of things,
yeah,
same. Like
yeah.
it's, if they can learn it for themselves, like then, their ability to get stronger, to live better, to live longer, to be able to do more things longer, just continues to increase, like longevity wise. I feel like there's like 1,000 other things that we could touch on all of
Yeah.
this. I think we need to do like a hormonally based one, like how hormones affect the pelvic floor, specifically as we age, and then also throughout our menstrual cycle, like that fluctuation. Men being involved in pelvic floor,
Yeah.
being a completely different conversation. And then you and I were talking earlier, like specifically about the sexual health component, and sexual health as in it's okay to say, I think, sexual pleasure for women, like this being a huge component of women's ability to enjoy sexual pleasure or orgasm, or achieve climax, or not have pain with intercourse, or any of those different things. It's
Mhm.
so like it can be so deeply correlated to pelvic floor, as well. So I
Mhm.
think there's so many things that you and I could talk about continuing
I know.
this conversation, but it's been an hour, so I'm trying to be respectful of time here. Um,
So, yeah.
no,
So
go.
what was the first thing you said that we were gonna
Hormones.
hormones? Yeah.
Yep.
So, the impact that hormones can have on our entire muscular system, not just our pelvic floor, is big. But
Mhm.
yeah, the absence of hormones, um, in like first, the absence of hormones really can impact pelvic floor.
So you're
And
meaning
not
like, and you're meaning that would be somebody postmenopause, um,
postpartum, postpartum.
postpartum,
Yeah, if there's
and
breastfeeding,
yep. So
hmm
postmenopause, postpartum, um,
or perimenopause. So for some reason, like, I mean, this could
fluctuation,
even be like what?
fluctuation in hormones
Yeah,
and
yeah,
perimenopause.
yeah, yeah,
The
or
other one
like
I'm thinking of,
imbalance.
hysterectomy, or
hmm
cancer treatment, breast
Breast
cancer.
cancer treatment. That was another thing that I had on my pelvic pain list too.
Yeah.
That's another time. But um, yeah. So the hormones, they play a vital role our in muscle fiber and ability to maintain and create more muscle fiber, and in addition to, like in terms of sexual function, lubrication, and like sensation and things like that. But um, the hormones in general can contribute to atrophy, can contribute to laxity within tissue. So going to someone who's postpartum. So me, for example, I've been nursing for 2 years, and so I have had to, it's essentially like I've been in menopause for 2 years, and it's it happens pretty quickly where you start to see some changes, and that can be um, maybe you're not able to withstand as high of an impact of activities. Maybe it's somebody is having incontinence, or again, like some of the stress incontinence, pain with intercourse. Like all of these things can be linked to estrogen, and a lot of them can be helped by vaginal estrogen. But speak with your doctor.
Yeah.
And but same thing when, obviously same thing, but to a larger degree in menopause, when it's not as short-lived. um we stop getting the um hormones to, or the hormones that are contributing or assisting with that stop, so we can get vaginal atrophy, and it can just continue to get worse, and cause a lot of symptoms. So I think it's something to really be aware of. Having good awareness and good um, strength or function of the muscles within the pelvic floor and within the core going into these stages of life is definitely going to help. So, if you're in perimenopause, now would be the time to really improve your awareness, improve your function, or at least address and make sure that you're doing things right, it's just going to be easier potentially, or, there's going to be better longevity.
I feel like our generation, the generation in menopause right now, like I example, like my mom, like just living with incontinence essentially her whole life because
Mm-hmm.
that was considered, normal. Now we know maybe common, but not normal. And now, like this, our generation, hopefully bringing more awareness and more intentionality to the rehabilitative options that we have, and like utilizing practitioners like yourself to set ourselves up for, optimal function, optimal movement, optimal pelvic floor function, core function, all of the, full body system functioning. If as we get into perimenopause and into menopause, seeing a shift in maybe the extremeness of the symptoms that you have seen in your career up to this point of women, the more mature women that are postmenopausal, like maybe we can mitigate some of that
Mm-hmm.
now, and start to change what that stage of life looks like, because right now the education on menopause is very like, they're going to deal with this and they're going to deal with vaginal dryness. They're going to deal with, incontinence. They're going to deal with lack of sleep. They're going to deal with this. So, like all of, inability to necessarily put on muscle, like all of these different things, like that, is talked about that makes menopause sound so fun. Um, as far as
Sign me up.
right, symptoms wise, but if we're doing the things at a younger stage and being intentional about the way we're training and being intentional, and maybe it is hormone replacement therapy for some women, maybe it's not, depending on the individual, but like how that maybe will look different in the future for, us, our generation. I'm older than you, but the generation maybe getting close to perimenopause now.
Yeah, I hope so. I hope that, and I really think so.
Yeah.
I think that the awareness of pelvic floor dysfunction, or, these things that we've talked about, has greatly increased in the general population. Like, I
Mm-hmm.
think we were talking the other day when I started, there was one other person in town. Well, there were two. One of them moved away. I took her spot, or, kind of thing.
Mm-hmm.
And now there's a lot more. And
Right.
that actually is great, because again, all of, I guess, kind of my point in highlighting all of these different things that can go wrong, quote unquote, is that it's there's because of the variety, we need a variety of people that both enjoys treating these different things and is skilled at treating these different things, because it's not all just the same. It's
Lay on
just not all the same
Yeah.
thing.
It's not
It's
all just lay on your back and get an, internal exam.
no, it is not. No. So for everybody that does need to do Kegel contractions, or be able to um be able to let go, and the same probably number of people can do um just external exercises and improve. But having a thorough evaluation in order to know those things is important,
Yeah.
I think. And
Yeah.
hopefully that is something that contributes to like improved longevity. And not, I guess, even in longevity in terms of like a longer lifespan, but like
Quality of life.
ability to, yeah, quality of life
Mm-hmm.
for longer.
Yeah,
So,
I agree. I think that there's a lot that we're doing within this generation, the work you're doing, the work that we're trying to do, to hopefully, I think that menopause could look a lot different for a lot of women
mhm.
in the future versus, unfortunately, the way that women have been served up to this point being so different.
Yeah, like
Um,
really positive,
yep.
like a positive new life stage, not
Yeah.
the end of your life. Yeah,
Yeah. Or the end of
as you know
your
it or whatever.
lifespan.
So,
Yeah, like the end of your vitality. Like you still have
yeah.
this vivacious life still to give and to live. Which I mean, Mary Jane and I will talk more about tonight, I'm sure
Yeah.
as well. So,
I'm excited.
but I leading into, I think I've decided that the next time we talk, we need to talk on the sex word, and we're gonna make this a thing. We're gonna bring it to light. Um, and my question for you is leading into that. Sometimes, and maybe not everybody does this, maybe I'm just weird. I'm just gonna be vulnerable here.
Oh,
Sometimes when I do a Kegel, usually like the first time, I get like a whole like body
like
chill.
this.
Like yeah, like a shake. Like it's a
Sometimes
shake.
people get that when they go pee too. Have
I
you ever
can
had
get that
that?
sometimes when I pee. Usually, sometimes
Yeah.
I chalk it up to like maybe I'm cold, like first thing in the morning or something. But what is that?
It's a
I'm
nervous
thinking it's
system response.
nerves.
It's a nervous system response.
Okay, is that
Yeah.
normal? Like it's just
Yeah.
a okay.
Yeah. That's normal. It's yeah.
I actually
But
was.
it's fun. Yeah.
You watched the video I did a Kegel a little bit ago, and you can see like I kind of shook for a second, and I'm like, I should ask her about that because
You're
I
like,
don't
I'm trying to, am I doing it right? Ooh.
know. Well, it's like if
Yes.
somebody says Kegel, it's like almost impossible not to do one, you know? Like when you hear it,
Well,
it's like once it's
there's,
ingrained.
yes, I got to check to see if I'm doing that right. Am I? Yeah. So
Yeah.
there is a significant amount of nerve endings, yeah, in your pelvic floor, right? And that is something that we can talk more about in the sexual function because that 100% has to do with our sexual function.
Yeah.
In the way that in all of the nerve endings and the things that we have going on. So, but yeah, like, you know, when you're activating that,
Mm-hmm.
it activates the whole
Shudders.
pelvic
I
floor.
know.
So I bet you're doing it right.
I would have hoped so. It's not like it like gonna orgasm or anything. Not that
Right.
it's just like a full body shiver. I'm like, does anybody else do that? Like, I'll just ask publicly here. I'll just ask.
Oh my gosh, that's great. I love it. That's so good.
Just gonna ask her. So yeah, stay tuned for that episode. I'm sure I'll have plenty of other questions in that regard. But thank you so much
Yeah.
for your time, for your work. I said this yesterday to a friend at lunch, like with you. Was that yesterday? I don't even know when that. I think it was yesterday, 2 days ago. I don't remember.
That was 2 days ago.
2 days ago. Uh, just how well versed you are in the way that you practice is, I know, so unique. Even when you left the table to go treat a patient, she was like, well, we can't find that again. And
Oh.
I was like, no, we can't. But not only using your platform to educate, just women like myself, but other practitioners, and women that don't know as much as maybe I know, in that regard. So I just keep doing what you're doing. I'm super proud of you. And I know that it is so needed in so many different areas. And I'll put in links like where people can get a hold of you at Wellity, to get scheduled and get seen. And you're taking insurance now, so I'm sure that's going to be very exciting for all involved. So utilize, especially if you're using up your deductible, we might as well start getting on the books with Beth. So, thank you, and I'm sure again, stay tuned for my weird questions on sexual health.
Well, I am every single time so happy to be able to chat with you. I mean, whether it's on a podcast or whether it's not. So it's just a joy. And I always leave laughing.
I know, at
But
least.
yeah. So yeah, I'm excited for the sexual health one coming up. So
Yep, we'll have some fun, I'm sure. Stay. Maybe
all
we'll
right.
have a glass of wine for that one. Just like sip
I'm
and make things a little bit more casual.
Maybe we should do like a couch
I
situation
think
where
we
like
could with some wine and some like
yeah,
blanket, and we'll grab
yeah,
some
like
eggs. Yeah.
it would be kind of weird if I was like drinking my wine now. I don't know. Maybe it wouldn't, but it would
No,
be more fun.
we'll set that up. We'll make it fun that way. Yeah.
Okay.
All right,
All
girl. Well,
right.
thank you. Thank you. Thank you
Yes.
everybody for tuning in, and we will chat soon.
Okay. Bye.
Bye-bye.